And together, we will move mountains. And if they don't hear our message, then we'll just do it over and over and over and over 1,000 times again for you.
And I'll rise up, I'll rise like the day, I'll rise up in spite of the end. I will rise, we will rise, we will rise, we will rise.
Hello, my name is Michelle Zabel, and I'm an assistant dean at the University of Maryland School of Social Work and the proud director of the Institute for Innovation and Implementation. So this year of working virtually has necessitated some really creative approaches to conferences. For us, we've spread the Training Institute workshops over the last 9 months, hosting just a few workshops each month. And I want to thank you for joining in these discussions and participating each month. This summer, we're continuing the Training Institutes in a way that will allow you to take us wherever you go. And I am hopeful that you are able to take a break and get away safely. We're going to be recording our summer workshops and releasing them each month so you can watch them anytime during the month that works for you. These workshops are going to be on a wide range of topics, all focused around strengthening your skills as you support children, youth, and families. A quick note, some presentation reference information and graphics that are embedded within the presentations may not be fully explained within the audio, but all of the presentations are accessible to download, as well as the resources and handouts that correspond to each workshop, and I encourage you to do that. Thank you for listening to the audio recordings of our summer workshops for Training Institutes Live. While you're enjoying these summer months and workshops, we'll be planning and working towards future Training Institutes when hopefully we can all see each other in person. Take care, enjoy your summer. Thanks.
So welcome to the Training Institutes Live. Today we're going to focus on implementing mobile response and stabilization services. Such an important topic as we move past COVID and young people return back to school. This is a really important topic for all of us to talk about. Today we have some great faculty with us. My name is Liz Manley, and I work at the Institute for Innovation and Implementation at the University of Maryland School of Social Work. And I'm joined by Shamika Williams, the Director of Children, Youth, and Family Services in Oklahoma. Craig Walters is the Director of the Utah Department of Human Services, and Ann Polkowski, who is the Director for the Division of Family and Children's Services in Nevada. So we're very, very happy to have everybody here with us today. So I'm just going to quickly take a couple minutes just to do a national overview of what mobile response is and some of the activities that are happening across the country specific to mobile response and stabilization. And we'll start by just talking about this paper, this Making the Case for Children's Crisis Continuum, which was published in 2018, that focused specifically on the role of mobile response and stabilization in a good and modern system that has multiple other components within a crisis system, but that mobile response and stabilization is a really key component if we want to shift the way that we begin to think about children and families. And some of the designs of mobile response and stabilization allow us to get to families and children in an upstream way, that we meet the needs of children and families because parents are reaching out asking for help and we're sending it, that we're able to de-escalate and ameliorate crisis before we have to move to more restrictive interventions and services. And it's a key shift for states from the overuse of the highest intensity of services, which are the most restrictive, most costly, and generally speaking, not used in a way that they're intended. I'm really happy to say that this work has been going on for a long time. States like New Jersey and Connecticut and Oklahoma have been at this work for a while. But we started in 2016 in New Jersey as part of the Institute partnership with the Department of Children and Families in New Jersey and Connecticut, and with some real great partners from Wraparound Milwaukee. We started to come together and bring states together to talk about what mobile response and stabilization is, what the impact could be, And these are all the states and communities that joined us in those conversations. And I think it's just really powerful that today we also have Oklahoma who was there, we have Nevada who was in that room, and we have Utah joining us because they have started to move these services along. And some of those conversations started really during that time in 2016 and 2018. And part of the reason why we think this work is so important is because it meets a sense of urgency, which is a core principle in systems of care, and the sense of urgency that families feel in that period of time when they begin to see that their children are demonstrating some shift or change in their behavior, and that period of time when they can get help in a crisis-driven system in an adult model is really dramatic if we can cut that period of time down to the time when parents begin to notice, and we send help at that time. What can happen for children in the long term is just really remarkable. Today, we're going to share some of those stories and some of the impact that we're beginning to see in the states that have really started to invest in this particular area. It's really important for us to talk about the difference between children's crisis models and adult crisis models. There's a lot of conversation right now across the country around building crisis models, and some states are considering using an adult and child model that really is sort of interconnected. As they say, it's across the lifespan. And we want to see services and supports across the lifespan, but we want customization for children for these particular reasons. We want a single point of access because in the world of a single point of access, it means that we don't ask questions about whether or not the child is in an escalated crisis that is defined by the crisis team. We allow parents and caregivers to define that crisis because they've been in it and because they're escalating and trying to manage this crisis system, this crisis that's happening for them and for their families alone. And we want to send help at the time that they identify that they need help. Instead of a care traffic control model, which really allows the professionals to make those decisions about when and how resources are going to be used. In the world of children's mobile response and stabilization, parents ask for help and we move. And we've always found that movement to help parents and families are worth the investment in doing that. The crisis is defined by the parent or the caregiver, that there's a comprehensive children's assessment, not a crisis assessment in the way that you would think about it in an adult model, but a specific crisis children's assessment that takes into consideration all of the things that children can be up against, that we respond always without law enforcement. It's really important as a core concept that we're not introducing a higher intensity of service than is necessary to meet the needs of our children and families. That we're specifically trained workforce to meet the needs of children, right? That the teams that go out know how to engage children, youth, parents, and caregivers in a way that's really impactful for them. And that's really important in this conversation because well-trained workforce can be really the turning point for what happens for these children and families, not just in the moment, but over the long term, in terms of the long-term trajectory for these children. We are designed to interrupt care pathways that take young people into emergency departments, into juvenile detention centers, and into the child welfare system. That stabilization services are really a core component of this work, generally provided by the same teams, although there are models that allow us to look at different ways of providing stabilization services. It is a core component of the work. And that those community connections that young people need are really part of the work, even more important in some instances than the connection to more formal supports like outpatient care. I'll just note that in this slide, you'll see that we talk about providing transportation as an adult crisis model, core component of adult crisis model. I just want to say that in the mobile response work, we're keeping our children in their homes, in their schools, and their communities. Transportation isn't a necessary component as that part of the work, right? We want to make sure that our children stay in the same bed that they were in at the time that we responded to them. This is a chart, right? And those of you who are listening, I'm just going to walk through real quick that we put together some resources that are important for states to consider as they're looking at their crisis systems to compare adult models, what mobile response is, and where they're at, right? And the reason we put this checklist together is we want to make sure there's clarity around what is necessary for children versus adults, and that states and communities are going to take this opportunity to expand their services, even if they're just checking off one or two more boxes. So very quickly, we're just going to talk about some of the things in these charts. The availability of 24/7 in-person response. There's a focus on cultural and linguistic competence. Mobile crisis intervention is about de-escalation and about engagement strategies. That there's on-site, face-to-face therapeutic response. And that's always the response. That there's that the teams are available within 60 minutes within any part of the communities that they serve. That there's a comprehensive children's assessment. It's specifically trained staff, which are really important. That the crisis is defined by the parent or the caregiver. The law enforcement conversation that we talked about. That there's partnership with child serving systems like child welfare and juvenile justice. They understand how and when to use the system, including pediatricians and family care practitioners. We want to make sure that we have understanding of when and how 911 is used. And 911 is not the single point of access for mobile response and stabilization, but there's knowledge of local resources, that all of this work is to keep young people out of hospitals. This is really important work as we move through, that there's non-emergency police response. It is part of an adult model, but not a child's model. Right, children's models do not include law enforcement as part of the response team, but they do include law enforcement as part of the planning team. They're part of the folks who actually help families connect to mobile response and stabilization. So we train them, we help them use mobile response, we let them know when and how mobile response is part of that team. So really important work that mobile response teams are connecting to law enforcement, to pediatricians, to the educational systems. Right. So that's a really important part of these conversations as we move forward in the model development. Mobile response and stabilization requires leadership. It requires leadership to transform the way that we think about children, the way that we think about parents and caregivers, and to create the conditions that allow us to shift away from language that drives some children's behavioral systems to speak about children in their primary diagnosis as if that is who they are. We don't talk about diagnoses as a driver. We talk about what the underlying needs are for their children, what will help them feel better. And we're going to talk with our children and families about what connections will be important. We prioritize the voice of parents. We focus on creating access points that are equitable in their nature, and so that parents across all communities feel comfortable reaching for assistance and getting it in a way that is meaningful. That we create feedback loops, and those feedback loops allow us to know how we're doing. That there's true equity. True equity means that any parent can ask for help, they can get it, and that help is going to come to them with folks who are trained in the culture that they're responding to, that they come from the communities from whom they serve, and that there's no bill that comes. This is not prioritized by payment mechanism. It's prioritized by the needs of families. It's really important for us to begin to think about how a service like mobile response and stabilization is really the way that we begin to interrupt care pathways that lead to the most restrictive, most costly services in our system. A single point of access, as we've talked about already, I'm just going to walk through a couple of core components one more time. It's generally a call center that you answer the phone 24/7 with folks who are trained to speak to parents in a way that is engaging and thoughtful, that all calls are answered, that parent and caregiver they call, they ask for help, in the team's role, they go. That the initial triage is really about why parents are calling today, how the teams can be helpful, and that there's a warm handoff that's going to acknowledge things that we should know, right? The things that teams should know before they go, like, are there any things we should know about directions to get to your house, as an example, right? Are there Is there a dog in your home that we should worry about? Those kind of things are really important. That it's centralized, that there's a connection to mobile teams, and that there's data collection that happens so that we can begin to see trends and where we need to fill gaps across the state or any particular community that's being served. The interruption of care pathways is the primary goal of mobile response and stabilization. So mobile response and stabilization is an important tool in creating a good and modern system. And there's consideration for mobile response and stabilization in implementation and in its availability. It's really important for us to just understand where those interruption points can happen. They happen at pediatrician's office, as an example, in daycare centers, in traditional outpatient centers. They're really trying to help those early identifiers begin to see that when changes for children are beginning to happen, when the early stages and the signs come up, that mobile response and stabilization is an access point to be able to get and understand what's happening for that young person, make sure they get good connections to what is necessary for them to be supported and for their children to be supported. Two core components of mobile response and stabilization include the 72-hour component, which is face-to-face within an hour. Family defines the crisis. There's crisis de-escalation and assessment. Then there's up to 8 weeks of stabilization, which includes the connection to community supports and services, reconnection with activities that there may be disengagement from, such as sports or extracurricular activities within a school system, just as examples. That there's in-home clinical support that's available to help both the child and the family be able to organize around what was driving some of those crises for the family's definition of crisis. And then a connection to higher level of support if that's necessary. As the assessments are completed, do we learn that the child has a higher level of need? The core components, just very quickly, is an upstream intervention. It's the single point of access. It focuses on shifting the care pathway. It recognizes natural support intervention points. It recognizes the healing potential within communities, is available 24/7, and recognizes the exposure to higher intensities of service can be incredibly traumatic for both children and their families. We talked about systems coordination. We'll just mention it again, that we coordinate across child welfare, juvenile justice, family courts, education, pediatricians and primary care, law enforcement, emergency departments, and community organizations, just as examples. But it's important for mobile teams to understand who is operating within their communities and to really have a good scan of what's working and not working within their communities. Community engagement strategies means that they're paying attention to all the places in which young people can be part of, engaging in their own communities. Partners like yoga studios and places in which young people can volunteer are all part of the strategies for mobile response and stabilization. There are financing strategies that are important, including Medicaid, Family First, mental health block grant dollars, system of care expansion grants, blended and braided funding, and commercial insurance mandates. We're happy to speak more about the financing strategies if you're really interested in moving forward. And the goal of mobile is to support and maintain, engage, promote and support safe behavior in the home and the community, reduce the over-reliance on emergency departments and higher intensities of service, and assist youth and families in accessing the supports that are necessary, both in the community, informal, but also the formal supports that are really necessary to keep children and families safe. It's my pleasure to hand to Shamika Williams from Oklahoma to share what's happening in Oklahoma.
Great, thank you, Liz. Some of the national recommendations and the national model around mobile response and stabilization services. The state of Oklahoma, we pretty much begin to look at those recommendations and really what were the experts saying needs to be considered as part of a mobile crisis system. And so Oklahoma, being a state that is rural in proximity, the one way across the state of Oklahoma, it could take you every bit of 4 hours. In addition to the unique cultural capacity of our state, we have, a large number of Native American communities that we work with in the state of Oklahoma. In addition to that, we have communities that are considered to be extremely rural and frontier. And so we begin to develop and facilitate our models with considerations and the input of the federal model, but also thinking about what adaptations need to be made in order to fit the state of Oklahoma. And so I'm going to talk through some of those in part. As I mentioned, our system is really built off the national model and the recommendations for mobile crisis. We're also founded off the values and principles of systems of care. As a part of those values and principles, we really wanted to look at a model that, again, really gave the families the ability to really make choice in that. We wanted to create opportunities where the over-reliance of inpatient care was not an option, but where we can keep kids and families at home and in their community. In addition to that, we also looked at ways to maintain kids at a least restricted environment. And so when we begin to think about some of the things that were happening in the state of Oklahoma, those are some of the things at the forefront. You know, how do we create a system that responds to families who may not be in acute crisis, but also may be looking for a direction and a way in order to get their mental health needs met? And for most part, a crisis to a family is a crisis. And sometimes their ability to have the resources and the supports to effectively manage those crises are not there. And so again, we wanted to create a mobile response system that was able to aid those families as well, okay? So currently in Oklahoma, we use our 211 call center as our single point of access. And they are also our statewide suicide prevention contractor. At that single point of access, we have trained individuals who facilitate the call center. Calls come in throughout the state from anywhere, from parents, from families, from community members who have a concern about kids who appear to be in crisis based upon their identification and what their crisis is. Our call center has the ability to facilitate calls for these individuals to our 211 Center for Basic Needs in order to get their basic needs met, to hospital, to medical, fire, police, if in fact it is a safety or a crisis situation that is beyond or above what you would see in a mental health situation. And so our call center facilitates our calls in a way to best help our families who call our crisis line. And sometimes some families may call the wrong line. Our call center is 24 hours a day, 7 days a week. Our call center has the ability to really screen the calls and make determination around the level of need in order to be able to determine, are these crisis situations that need a mobile response? Are these crisis situations that need access to a mental health appointment? Or are these situations where parents and caregivers need resources in order to be able to talk through the situation or the concerns that they have? In addition to that, our call center helps to determine what other supports that our families may need as a result of the reason behind the crisis that they call. As a part of determining the level of care, when in fact our families determine that they are unsure as to what they specifically need in order to aid in that crisis, we're able to do what we call warm handoffs to our mobile responders. Our mobile responders are expected to do emergency face-to-face response within 1 hour. In addition to that, when in fact families don't want a mobile response, don't want that face-to-face within 1 hour, we require our providers to do face-to-face within 24 hours. So that can look in the lines of setting up an appointment, that can be sending a team out to meet with the parent or the caregiver at that particular time. But it's really important that our providers actively listen to the information that our families are sharing and really what's specifically going on to really determine if in fact it results in an emergency response, that 1 hour call. As a part of that, the call center triages the call in order to determine, are there areas of safety? Are these kids that have other concerns, medical concerns that are also a part of that? Are there any additional safety concerns that need to be considered as a part of that response? Do we need to respond with law enforcement because there are safety issues? Is there safety weapons? Is there weapons that are involved? In most cases, our responses do not take involvement with law enforcement, but there are some of those more severe safety issues that we have to respond with our law enforcement. In addition to that, also, are there medical needs that needs to be addressed? And so, do we need to activate our EMSA system as well? Our call, once our call center has the active calls, they're able to put the information into our data system really in a real time, so that the actual mobile providers have that information about the call available. Our call center does a warm handoff to our frontline providers who work on the front line in order to go out mobilely. As a part of that handoff, they're able to introduce the person that is calling and ask for permission to drop off that call. At any point in time, our calls are dropped. We have the ability to reconnect through those calls through our call center. In addition to that, it's also important to know that our providers have that real-time information that they can access through any type of technology device in order to get the contact information, the name, or information about the call as well. Our mobile response is set up in a really unique way. I mentioned that it is built off the foundation of systems of care and really wraparound. In the state of Oklahoma, we have a unique system where we actually have wraparound services statewide. What we found is that our wraparound providers are really comfortable working with families that are, in some cases, families that may be a little tougher in nature, but they're also families that often operate in and out of crisis. So our frontline providers are care coordinators, our family support providers, as well as licensed behavioral health practitioners. In addition to that, we always have access to our call center for that additional support around the calls, what they heard. If in fact some of those calls are lost and we're trying to reconnect with that family, we're able to contact our call center at that moment to really listen to recordings of those calls in order to be able to determine if we need to send law enforcement out because we're unable to get back in touch with those families that actually drop off. Also, as a part of our calls, when we're working with our families in order to activate our response, there are many times that we find, especially during the COVID times, that families want information. Families want additional support. And so our ability to provide the information and the support in a non-face-to-face response within an hour is really important. Sometimes families need to know in a situation that's a crisis and how to handle follow-up care, how to, facilitate the next step once a young person has calmed down. What should I do now? He's not actively aggressive anymore, but what should I consider in those responses? So our mobile team is able to provide some real-time knowledge and information and direction to those family members who are not able to do a face-to-face at that particular time, but may have a 24-hour follow-up. As a part of our mobile response, we have community-based authorization. When I talk about least restricted environment, it's important that families and providers that are working with families have the ability to authorize the next level of care when, in fact, that is needed. Our mobile teams have the ability to work with our inpatient providers, not just to be able to do LBHP statements. For that, they are also able to work with our inpatient providers to work with our healthcare authority entity, our sooner care agent, in order to authorize, in order to do what we call community-based authorization, to authorize a level of inpatient care for those young people. The reason why that is important in the community, because oftentimes the mobile team is the team that works with the provider agencies that often treat these kids, and so they know these kids best. They've been through multiple situations and scenarios with young people where they actively go into crisis. And again, the determination around the type of crisis, and if this is a familiar pattern, are we able to de-escalate these types of situations without looking for higher levels of care are really important. And so our community-based authorizers are our mobile teams who also work with community mental health centers. Okay? Also, this prevents families from having to drive clear across the state in order to seek that psychiatric inpatient care. In the state of Oklahoma, I mentioned earlier that one way across the state from far in the Panhandle to Oklahoma City, which is in the center of the state, could take every bit of 3 hours. And so our community-based team, our mobile team is able to authorize care, but then also to look for the closest bed space, to look for the location that will be able to provide services. And so families are not driving from place to place in order to get those. This is a pretty much a state map, and it's what we utilize as a part of our heat map. In the state of Oklahoma, we're able to look at a combination of things. We're able to identify counties where crises occur most. We're able to identify the time of the day of the week of the month that it occurs, the type, as far as are these crises occurring more in the schools, are they occurring more in the community. We're able to really help providers determine levels of staffing, how they need to staff up based on the call, based on the types of calls and the number of calls. In addition to that, it was important for us to be able to do some predictive measuring in reference to the number of calls that may have been substance abuse related in specific areas of the state versus the number of calls where suicide may have been up in certain areas, and so that we can do some of the back work, some of the front work on the front end around prevention and intervention, so before it gets to a crisis state. In some parts of the state of Oklahoma, we are highly involved with a technology infrastructure that allows us to do the LBHP assessments through our iPads, in addition to interfacing with our hospitals through iPads. And so our iPad technology has been used. In some instances, we have worked extremely hard to really look at their partnership with law enforcement, because we know that there are times when safety is an issue and you have. But in most cases, in the state of Oklahoma, and in most cases with our families, law enforcement is never a intervention or never a point of contact for us. But when in fact it is, we have worked with our law enforcement officers across the state to make sure that they're trained in CRT training, in addition to equipping them with iPads so that if they are the first point of contact, they can interface with us quickly, and so that we can begin to move in and intervene in that situation. I have to quote, and I have to restate it, in at least in situations where safety is an intimate thing, but when in fact it's not, specifically on the children's side, we don't want to utilize the time of law enforcement to do those types of interventions. Oklahoma, there's a couple of things that we have really scaled up about. Currently right now, what we know is if our mobile team is able to interface with kids across the state of Oklahoma, we're at a 79% diversion rate. Our diversion rate is about 83% if we're able to intervene in schools. We know that when trained mental health professionals interface with families, we're more than likely to be able to divert those crises. And what we also know is what a crisis looks like for an adult. It's not the same type of crisis in most cases that it doesn't look the same for kids and families. And sometimes it's our parents that we have to work with to get them out of that crisis state to be able to help with the kids. And I say that because oftentimes our families have been overwhelmed, especially through COVID. The overwhelming of families oftentimes can really have an impact on our young people. All right, I will turn it over to our friends in Utah.
Thank you so much. I'm Craig Walters. I'm with the Utah Department of Human Services. And I'd like to talk today about 6 key changes that we pushed forward in Utah, from shifting the crisis approach, the growing demand in Utah for children and youth, what we're trying to impact with our Stabilization and Mobile Response program, the interesting approach we have to our partnerships, an understanding of the 3-phase approach for Stabilization and Mobile Response, and then have an opportunity to show you some of the outcomes we've achieved over the past couple of years. So Stabilization and Mobile Response sits within the Office of Quality and Design, which is where we operationalize our system of care approach. And Liz hinted to this earlier, but language matters in this approach. And what you'll see throughout the slide in our marketing materials on our website is we don't use the word crisis. We actually use the word challenge, and that's intentional. We're wanting to engage with families that might be deterred from that word crisis, that may say, I don't want the 911 services. I'll deal with this later. This isn't serious enough. I'll figure it out on my own. What we want to do is make sure that we're responding to more than just imminent risk. We want to broaden our approach to beyond just de-escalating a challenge or a crisis at the hand and get to the root of the challenge that family is experiencing. So our approach, much like all of our actions with our system of care, are family-driven and they're youth-guided. The family has to be engaged in each of the phases, and the child and youth have to be engaged and drive the actions that we do with stabilization and mobile response. We're also using a CANS-based assessment in Utah, the UFACET we've developed with the Pre-Ed Foundation, a tool to help us understand what is at the root of this family's challenge. With SMR, we don't have a long time to engage. We want to identify quickly. So this tool is really focused on, as we work with this family, what are the core components that are leading to their challenge that led them to engage with us today? And the other really important part is, as in Utah, we expand stabilization and mobile response across our state, which, similar to Oklahoma, there is a lot of frontier and rural areas of Utah. It is important that SMR becomes the first point of contact to a greater system. Those children, youth, and families may need something more intensive than what SMR can provide. And what we want to build as we expand are those connections and the strength of the community around that SMR administrator in that region to find community solutions and community answers. Okay, and what's important to me is to talk about attributing factors to a family's challenge or the crisis at hand. I know in this industry, we all have an understanding, lack of access to services and resources, but why we elevate this whenever we talk about stabilization mobile response in Utah is because it's an individualized approach. It's a region approach. It's very different for the families that are experiencing challenges in the southernmost part of Utah versus Salt Lake, the most urban areas of Utah. Those challenges are very different. And those challenges vary not only from family to family, but community to community, region to region. And it's so important in our approach as we roll out SMR across the state that our administrators are embedding themselves in regional structures. And we'll talk a little bit more about how we're doing that in Utah through our regional advisory councils. Now I'd like to talk a little bit about the growing demand. I know we see this nationally, but this is an important and a really big piece for Utah. We can go to the next slide. What this slide, and I know it's hard to see some of the data points on here. This is some data from one of our non-traditional partners. It's from Intermountain Primary Children's Hospital. It's one of the largest healthcare organizations in the Intermountain West, who has joined our organization through an in-kind donation to expand SMR in a very rural part of Utah based on this data. And what this data is showing is emergency department visits that require a crisis evaluation. They're seeing these children and youth and families coming to their emergency departments because they don't know where else to turn to. And their concern is the emergency department providing them the service they need? At the end of that emergency department visit, that child, youth, or family may have a referral to an inpatient bed, but most likely, if the social service worker isn't available, they've waited hours, meaning they've taken up capacity from children and youth with physical health issues, and then that doctor who may not be equipped to address those scenarios, that family leaves with an emergency room bill, and that family is now no longer or no more equipped to manage that behavioral, developmental, or mental health challenge than when they got there. It might have diffused or ameliorated, but what our partners at Intermountain are seeing is there's got to be a better way to help them find a sustainable solution. This data is from now our more traditional side. This is through our Division of Substance Abuse and Mental Health, our outcome scorecards. It's a public scorecard. But why this data is so important is it's showing an increase in the number of children and youth that we've identified as in need of service. So between 2016 to 2019, we saw a 66% increase in the number of children under the age of 17 that have been identified as needing services. And sadly, there's a growing disparity. We're identifying more and more, but we saw a 48% decrease in the number of children that were identified that actually got services. So we have a growing demand both in the non-traditional part of our system, and in this traditional local mental health approach through our division of services for substance abuse and mental health. So what are we trying to impact with stabilization and mobile response? We are focusing on reducing the utilization of emergency departments and law enforcement when children, youth, and families experience behavioral, mental, and/or developmental challenges. Developmental being a very critical piece of this. In most crisis systems, especially that have a clinical threshold, Liz was referring to this earlier, the children, youth, and families that have children with developmental challenges may not reach that threshold, and therefore they don't get a response. And therefore they languish until their challenge becomes so deep, it's going to take a massive level of effort when we could engage with that family sooner, break those cycles sooner, connect them earlier. And our department's focus is to keep children, youth in their homes and communities. So we can skip to the next slide because that will show this a little bit better here, but you can see we've got a lot of partners in Utah, and here's why. Utah is massive. We've divided this into our system of care 5 regions. We identify a single administrator in each region. Just recently, through a SAMHSA, a system of care expansion and sustainability grant, we'll be standing up stabilization and mobile response in the eastern region, that sort of gray, very long region on the far side. Through a donation from Intermountain Primary Children's, we stood up stabilization mobile response in Salt Lake, and we did just through our legislature get funding for our western region. So we're working to identify a single administrator. Each of those administrators engage in a regional advisory council who are made up of community members, school districts, law enforcement, members from our Department of Human Services division, so juvenile justice, child and family services, the local mental health authorities, families that have engaged in the system that had great outcomes, and families that engaged in the system that had challenging outcomes. So they work together. They are held accountable and stand arm in arm with the members of their community to find the solutions, to identify gaps. For example, in our eastern region, which is very rural, we already know as they're standing up, there's a lack of services around autism. So as they engage with their community and learn and stand up SMR, they're already working with their community partners. What can we do to solve that problem as we start to identify these children? Because we know as a member of this community, that is an issue and a challenge for our community members. So this sort of recaps our approach. Stabilization and mobile response is for any family with a child under the age of 20 with behavioral, mental, and/or developmental challenges. It is voluntary. There is no cost to the family. It's blind to their insurance or resources they have. The family is part of this solutioning. We do have a central number that is manned 24/7 through a partnership with our crisis line. That was a pilot that we did to prepare for 988 and test out. That crisis line identifies, hey, this is a safe fam number. We follow a very special protocol then, and we get it to our SMR administrators in that community who triage the call. And this is the 3 phases. So when we talked about that triage, the crisis line sees that 833 safe fam number pop up, and they follow a precise protocol, quickly identifying, hey, what community are you in? What are your challenges? Let me connect you, transferred to that SMR administrator who provides the triage. They work with the family on what's the challenge at hand. Can we refer you to some services? Do you want a problem solve on the hand? Or do we work together to say, yes, you want a mobile deployment? And they go through some of the triage process to better understand, hey, what's going on in the home? Is everybody home? Are there weapons in their home? Is there a dog? Are you concerned about COVID? Can we meet in the driveway or in the backyard so we can have safe distance? If that family decides a mobile response, that family decides how we deploy. Do we deploy as soon as possible? Yeah, we have a team wrapping up the service in your area. We could be there in 45 minutes. Will that work for you? Or the family can decide, you know what? Actually, Craig went to his cousin's for the night. How about tomorrow after school at 5 o'clock, the family would be there. Great. Well, we'll plan to have a team at your home tomorrow at 5. We do deploy in a 2-person team with a caseworker and a clinical level worker. At that mobile response, we do risk assessments. We're working on de-escalating the challenge at hand. We can implement immediate stabilization through safety planning, behavior planning, parent to family coaching, and respite, both formal and informal. Maybe they can go to the neighbors to cool off for an hour while we separate the family and calm things down. Or maybe we actually have to engage the family with some of the formal respite services in the community. Once that mobile deployment and the immediate issue is sort of ameliorated and calmed down, we use a needs-based assessment to determine, did they meet eligibility for the 8 weeks of stabilization services? Again, this is voluntary. There's no charge to the family. And during those 8 weeks, we're working to connect them to natural supports, community supports, what is going to sustain them past these 8 weeks and past the 8 weeks of follow-up once we've completed the stabilization. The intent there is really to increase the family's ability to manage these challenges that are lifelong challenges. They're not going to go away. So what can we do to help them be more capable and able and connected to manage those? And if 3 months from now that family needs to re-engage through the phone and triage and start that over, we're here for them during that process. So really quickly, I just wanted to give you an example of our outcomes and that we track. So we tracked some performance and outcome measures, some system measures. So you can see the utilization of each phase. This is based on fiscal year 2020. We just wrapped up state fiscal year 21, so my data is just on the verge there. We don't have it available just yet, but this gives you a good idea before expansion. We had over 1,538 families utilize the triage service, 870 moved on to mobile deployment, and sorry, this is in my way. 362 moved on to the intensive stabilization services, which includes those 8 weeks of follow-up. We track a lot of information through this, how many remained at home, how many also engaged with law enforcement and police department. And I'll show you that data if we go to the next slide. I'll call some of that out. So really importantly, I wanted to also demonstrate to you increase in utilization. This is without expansion. This is just through communities hearing about, family to family, school district to school district saying, hey, this really worked for a family. This really worked for us. So we saw it without expanding. This is before any of our expansion, an 87% increase from 2019 in utilization of our triage, the 833 safe band number, a 76% increase in mobile response utilization, and a 128% increase in the utilization of intensive stabilization services. In 2020, we deterred over 123 children and youth from engaging with law enforcement, and a disparate 123 youth from engaging with our emergency departments when they were experiencing behavioral, mental, or developmental challenges. You can see through to date, so from 2019 to April of 2021, our utilization rate. To date, over those years, we've deterred over 428 children and youth from emergency departments and 322 children and youth deterred from law enforcement. I don't know if you guys saw the news, but last year we had a young child, a 12-year-old boy that was shot when his mom called for assistance. That young child had diagnoses of autism. And so when that police force engaged, we can see the challenges there with engaging in law enforcement. Law enforcement don't have a tool that we would ever determine as being an appropriate response for a child or a youth. And really quickly, I wanted to let you see some of the ages we're engaging with. Right now, we are in a targeted initiative to try to push into the younger age groups. Right now, our largest utilization is adolescents from the age of 14 to 17. But just behind that is that 12 to 13 age group, which is really exciting. And what is a positive piece to me, but shocking, is that infant less than 12, we have now engaged with 3 children in that age group. That's important to me to say it's possible for us to support families with these younger children, but it saddens me at the same time that families need those. But this is sort of an interesting opportunity for Utah, where we have identified through some of our partners and stakeholders that Utah has a gap in services for that 0 to 6, 6 to 12 age group. And that's an opportunity for SMR to come into this continuum and see, can we engage with those children there? And we can go to the last slide. So this is an important quote to me because it gets to your point, Liz, that you mentioned earlier. The idea behind SMR is not that families have to bend to these systems. Historically, in social services, government systems, we make the families say, bend to us, figure us out, you come to our facilities. And SMR is so important because it says to those children, hey, we know you're struggling. It says to those families, we know you don't know where to go or who to turn to. We'll be there for you. We'll answer. We hear your call for help. And I will turn it over to you, Anne, in Nevada.
Thank you, Craig. I'm Anne Polakowski. I'm a licensed clinical social worker in the state of Nevada, working with the Division of Child and Family Services. It's an interesting place to be, being the last person to present. A lot of what I had already presented in my slides has already been stated, and I have to follow Craig. So here we go. Mobile crisis response in the state of Nevada has been provided by the Division of Child and Family Services since 2014. And we started very small in 2014 in response to youth being housed basically in the emergency departments for mental health and behavioral health reasons. So much what Craig had talked about as well. So we started with the mission to help Nevada's children and adolescents to be able to live happily, safely, and productively with their families while remaining in their homes and in their communities. And that's really, really important. We know that children do best when they're in environments that they know, with family that they know, and with communities that are going to be able to support them. So our goal is to keep them in those communities and to find services and supports in those communities that will help them thrive and move forward. We want to promote that in a safe way and to keep them in there safely. We want to reduce those admissions to the emergency departments because that is not where these youth need to be going and receive the treatment and the connections that they need down the road. Sometimes for safety, we do need to facilitate those short-term inpatient psychiatric hospitalizations, and we're able to do that. And then we assist youth and families in accessing and linking to their ongoing supports long-term if they need that at the end of our services. Much like you've heard from the other presenters, we respond immediately to youth and families, and crisis is also defined by the caregiver calling in. Sometimes that response is immediate. We can be there within the hour. Sometimes it's delayed, much like you've heard already. We work within the Nevada system of care values and principles, and we utilize child and family teams to make decisions. And families' voices are very, very important. Family and youth voice is very important to the work that we do and the direction that we take in mobile response. As I mentioned, the services are provided by the Division of Child and Family Services in Las Vegas and Reno. In our rural areas, we partner with Department of Behavioral Health, who provide services by telehealth. Nevada, like Utah, is huge in geographic area, but not huge in population. So we have a bit of a hybrid model. It looks one way in the rural areas and different in the urban areas. So I'm going to talk through how those models look and how we roll out services directly to youth and families in the different regions. So in Las Vegas and Reno, the calls come through the hotline. That hotline right now is operated by DCFS. We answer all of those calls and do a very quick triage, same things that you've been hearing in terms of what is the initial crisis, how can we help you, and are there any safety concerns, and how do we get to you, which is very important. As Liz mentioned, you have a gate code. What apartment building number do you have, so that we're not spending a lot of time wandering around when we need to get to that youth and family. Sometimes they just need support. We sometimes get calls for resources or connections, and we're able to provide all that. If they want us to respond and dispatch, that's what we do. We send a team of 2 in the urban areas, a mental health counselor who's a master's level, and a psychiatric caseworker who's a bachelor's level. We do an assessment. So the clinician, I'll talk about the assessments actually in a second. We do an assessment, determine and implement the next steps, which could be stabilization, but I will get into that in detail in the next slides, all of those. So when we respond, the master's level mental health clinician conducts a standardized semi-structured assessment. And like you taught, it comes from the CANS as well. And in we call it the crisis assessment tool. We assess both current and recent history of risk behaviors, any mental health concerns that youth has had or is currently having, and functional impairment. We do this and we have a structured assessment because it really allows the clinician then to judge risk levels in key areas so that we can create safety plans for that youth and determine or make recommendations for our next steps. At the same time, our psychiatric caseworker is doing a crisis needs assessment. And what this is also a little bit structured, but less, and we are looking at all the domains of this youth and family. So we're looking at the strengths and any gaps or deficits or needs that a youth and family might have in social, emotional, education, medical. We are taking a holistic approach at looking at what is working for this family, how can we leverage that to support this youth in this current moment, and being able to stay safely where they need to be, and where are some needs and gaps so that we know how to support the family and being able to support the youth. So Shamika talked a little bit about how sometimes we have to support the need of a parent or the crisis of the caregiver so that they're in a space where they are able to support their child. We do that quite a bit, right? Because if you're really worried about if you're gonna be able to pay rent next week, it's hard to be able to be in that emotional safe space to support your child. So we take a look at all of that as well in that first assessment so that we can start plugging in some of those support to that family. And at every response, we do safety planning. So regardless of what the next step is or what option we choose post-assessment, and that being the youth family, sometimes the medical professionals and our team, we do a safety plan. And this safety plan is looking at what were the behaviors that brought them in? What are some triggers, warning signs? We work with that young person to think about what are some of their internal and external coping skills, what are some of their supports. And we do this, and we do it in writing, and we share it between the caregiver and the youth, and we make sure that it is something that they can both work with. So if the presenting issue, for example, was bullying by internet, maybe using of your phone to access social media is not the best coping skill in that moment for that youth. And so then we work on what are some other options that maybe we hadn't tried that would be successful as well. And the caregiver is able to support those because we're doing this jointly. We also use this safety plan throughout our time in our stabilization services, because as you get to know the youth and as you get to know the family, more things come up and you learn more skills, and you want to make sure that they're documented so that when we leave, there's a document, there's something in writing for them to be able to refer back to and utilize moving forward in their lives. So at the end of our assessment, after we've done that crisis assessment tool, we've done the needs assessment, and we've done the safety planning, several things could happen. Some of our youth, a very small percentage, about 13%, do need to be hospitalized in an acute setting for a short time in order to stabilize the crisis that brought them to mobile in the beginning. Some of our youth are coming to us with community providers and supports, and this has happened when their provider's on vacation or on the weekend or in the evenings, and they need a little extra support in that moment. And so we will send them back to their community provider if that's what they choose to do. Most of our families engage in our stabilization services. We can stay involved with a youth and family for 30 to 45 days, typically, sometimes up to 8 weeks if that's needed. We continue to stabilize whatever the presenting crisis or presenting concern was coming in. We continue to ensure that there's safety, that there's planning, that we are linking linking them to the services that they need, and then we kickstart that therapeutic process. And then some of our families and some of our youth do not need anything. It was a miscommunication that can be cleared up in that assessment, and families will decline then for any additional services at the end of that initial response. In our stabilization for our families and youth that do move into stabilization, we are back out in that home within 24 to 48 hours. And this has really been helpful with our emergency departments in talking to the physicians about ensuring safety. So sometimes our emergency departments might be a little concerned about being able to send a youth home, but knowing that we are able to be back out there that next day, that next morning, within 24 to 48 hours, provides some safety net for this youth and family that they didn't have a decade ago. And so we go out in that first session, we develop a quick treatment plan. We continue to look at that crisis trigger at their level of crisis. How's it been in the last 24 to 48 hours? Are there any additional things that we need to put in place? And we review, update, and start implementation of that safety plan that we had created. We can be out there typically 2 to 3 times a week. So it could be every day if that's needed. It could be less often as needed. However, it's determined by the youth and the family about how often they want us there. We will be there. We work with that youth and family on things like communication and coping skills and safety. We don't dig into that long-term therapy like trauma and those kinds of things because we're not going to be there for long. So we really want to build that foundation and then do that warm handoff to the long-term provider if that's what's needed. The clinician is going to do some individual and family work, looking at those high-risk behaviors, the emotions, the crisis triggers, communication, family dynamics, while that psychiatric caseworker will work with the family to refer and link to formal and informal supports, which could be anything from TA and support with Medicaid and insurance applications to finding help with a food bank or utilities. So we really look at that, again, that holistic approach to how we support the youth and that family. Our rural look a little bit different. So you saw this slide a little bit earlier. Everything that is green and yellow is served by our rural mobile response team. So that is a lot of ground to cover, and there's not a huge team. So they operate a little bit differently in the rurals. All calls statewide come into the call line that I was talking about earlier. And if it's a call for one of our rural communities, we triage very quickly and send to our rural teams. Rural teams then respond via telehealth or by phone, but mostly by telehealth, almost 100% of the time, and can connect with a family within about 10 to 15 minutes is typically how quickly they are connecting with that family. They also perform the crisis assessment tool, but they're not doing that needs assessment piece formally in their initial assessment. And then their stabilization looks very similar to what the urbans are doing, except they are doing it all by telehealth. So what makes our rural and frontier communities or mobile response unique? They have been doing telehealth since 2016. So they were doing telehealth before telehealth was cool, so to speak. So when COVID hit and the rest of us were scrambling to figure out how we continue to provide services to our youth and families, our rural teams had that locked in. And they did, however, because they started it in 2016, run into some stigma of how does it work? And you can't do this by video, and it's not how services are provided. And so they really spent a lot of time building those relationships with communities and providers and families and law enforcement and hospitals to talk about how that will work and how telehealth in crisis situations in our rural and frontier areas can be effective. Families, on the other hand, were really liking it because in our rural and frontiers, there's not a lot of services like my colleagues have talked about. And so this was something that was available to them without the drive, without needing to travel multiple hours, and we could get to them very, very quickly and support them very quickly. So that was really a big thing for our rural and frontier families and youth. The team looks a little bit different. The clinicians respond by telehealth. There's a psychiatric caseworker who does some of the linking and monitoring that covers all of the regions. And then there's connections within each community. So there's rural community mental health centers that are a part of the network that the rural teams are connected to. And then in addition to that, they've built all of those partnerships that I talked about. we often get asked, what do you do when a family doesn't have connectivity or doesn't have internet access? One of the things that we've done in our rural communities is build networks with hospitals, with rural clinics, with schools, with fire departments, for example, and youth and family can go there and be able to connect using internet there in order to receive services. So we're trying to do different things to allow for those families who maybe don't have that bandwidth or don't have internet capability. And that was it. That is mobile crisis response in Nevada. And Liz, back to you.
Thank you, Anne and Craig and Shamika, for a wonderful presentation on mobile response and stabilization. We've added some resources for all of you to take a look at if you have any questions around some of the more specific things around mobile response and stabilization to take a look at. It has been our privilege to talk with you today about what we think is one of the most important services in children and families to change the trajectory in their lives. And it's been an honor. So best of luck. Thank you so much.